And that's a big misconception I see, because most conventional, when they approach it with ablation, whether that be radio frequency or whether that be the new histotripsy, they want to ablate all of it.
Yeah, right.
Which talk about that combination and how that activates the immune system.
Yeah, and I think it's a very important point to know that, because originally this was our thought. And then, first logically you think, oh, there's a tumor there, we're going to stick a needle in it, we got to kill that whole thing. I mean, I understand it. It makes sense. That's what we did. That's what we always did. That's the standard of care now. I mean, you go anywhere, you go to MD Anderson, Sloan Kettering, any top cancer center, you get ablation. They're going to ablate you completely, and they're going to get a margin. And that's what's they're trained, and that's embedded, and we're trying to get them to see it differently because we know, and I think I've mentioned before in one of the papers that we published out of Case Western, Alex Huang, I was one of the advisors on the paper, and showing that when we ablated part of the tumor, that actually the residual that we left behind, that tumor began producing immune stimulating substances. The tumor did, oddly enough. It was sort of like damaged, and then it produces these immune stimulating substances, which then recruited the immune response more. Whereas if you ablated the entire tumor, you did not get that benefit. And as a matter of fact, you got the counter, where you got healing growth factors, which supported regulatory immune cells, immune suppression, and cancer growth. So the way that ablation is done right now is harmful. And so it's unfortunate, but it is what it is. And we try to get people to understand this. It needs to be done a different way, that you partially ablate these tumors.
That brings me to mind of a phase 1 clinical trial published in 2016 on the preoperative single dose of ipilimumab and cryoablation in women with early stage breast cancer with comprehensive immune profiling. That's the name of the study. And what they found is that in the individual group of the ipilimumab and the cryoablation, is that there was actually an increased Th2 cytokine, which tends to be more of a pro-carcinogenic immune activation, but it was the combination.
Yeah.
Only in the combination group did they see the Th1 cytokine activation, which is more of an anti-cancer, showing that really almost each one individually could be bad, but yet the two together is really, really good.
Yeah, and obviously you can get away with ablating the entire tumor. Sometimes it works, right? And you can do that, and sometimes you don't get enough suppression. And certainly you add immunotherapy agents to it, you can overcome that somewhat. So, but we know that if we want to maximize this, and that's why I think the pulse electric field is a good technology, because in general, at least the system that we use ablate such a small area that it would be almost impossible for us to ablate an entire tumor. I mean, I know that the doctors in the U.S. who are using pulse electric field, they're trying to do this. They're making that's why they're not. That's why they don't like the technology, because it's so hard to do it. And the company, I think, is making a mistake, or they're looking to see how can we maximize this. How can we get bigger ablations? There's another competitor company that has a system out that has bigger ablations, and maybe pulse field is forgiving enough that you could do bigger ablations with it, and you don't have the issues that you have with cryo, because the technology is different. But the nice thing is that the technology makes it hard for people to get overzealous, and that makes it immune stimulating. And I guess we'll have to see on the bigger volumes.
So ultimately, the impact here is the abscopal immune response. And it's interesting that word, it's two parts. It's ab, which means away from, and scopus, meaning target. So it's away from the target. First described in the radiation literature in 1953 by Dr. R.H. Moll. And really, because of the single approach of radiation, it was a very weak and rare observation. But it's really the target aspect of the ablation here, particularly the PEF, and the combination of the immune therapy in proximity. And understand too, the published literature out there in the primary and the clinical world, that is human trials, though they're limited, it's one immunotherapeutic. What we're doing is creating a lot of new antigens for the immune system to respond to, and a lot of targeted immunoactivating agents all in the same mix. So it's not just a magic cocktail, it is a souped up magic cocktail.
Yeah. Well, for me, on my patients that I treat on regular situation, we're commonly using 12 drugs at each treatment.
Right.
And so, and that's kind of what we found that works really well in most patients and doesn't cause, a huge amount of problems. And so that's kind of what we find. Obviously we tailor and adjust these and there's different situations and depending on, what's going on with the patient. But yeah, when you're limited to mainly PD1, CTLA4, technically we have LAG3, FDA approved. A lot of limitation. I mean, you could also expand out like IL-15. That agent's approved. That would be a great one. But start thinking the expense. I mean, like Yervoy, $35,000 a dose. IL-15, $38,000 a dose. People want that. You start getting like those are super expensive. But yeah, we found I think a right combination that works really well. I think in the future, as we get more and more patients, more and more follow-up, we'll be able to kind of publish this and show, okay, this is the formula that we see that works well for the majority of patients. Is it the definitive cure for cancer? Maybe not. I mean, but will it cure probably a lot of patients? I would say yes.
Well, the important point there on that is there was a 2004 article, and check out the references in this podcast show notes because it'll be there. But where they were looking at the overall impact on chemotherapy with metastatic solid tumors, and they actually found only a 2.4 month increase in overall survival. Now, that was 2004, but they were doing roughly a 20 year review. And so when you're talking about what is considered, quote unquote, one of the pillars of standard of care, if we're extending that 2.4 to say 8 months, but here we're actually doing much longer, it really begins to take something from a acute situation where they're just trying to be palliative in many ways, trying to slow down the progression of the disease, to really it becomes one of more chronic. Now, as it moves chronic, there can actually be a targeted move to actually regress it.
Yeah.
So it's a very different concept, because if somebody is diagnosed with cancer and then stage 4 cancer, and then 30 years later, maybe the tumor is almost gone, but yet the patient's maintained the quality of life through that treatment, that seems like a win.
Yeah. Well, I think where we're going to find the real definitive treatment, which we're already working on, is and again, it's different for different patients, but for some patients, you're doing ablation, you're recruiting that initial heavy attack, T cell, B cell effector type attack, and then you're finishing it off with this myeloid attack, which is like, so it's kind of like imagine a war, and you got your main big targets, and you come in with like your Air Force and stuff like that, and you blow those up. But now you just got like a few little small stragglers in there, and then you send your ground troops in, and that's your myeloid people, right? That's they're like the ground troops coming, going hand to hand combat on these people on the cancer and killing it. They don't go with this aggressive blow up. That's why they don't really cause autoimmunity. They're like this direct attack, and we know now how to push that response. And so that's the direction where, I think we will see the ultimate cure for cancer with that combination. And that's of course stuff that we're doing right now.
And to bring it back to that fire that you mentioned around here in LA, the dropping the water, plane, that's more of the targeted, but then the myeloid response would be the firefighters right there on the front, trying to create the barrier. I mean, that I can see that.
It's exactly right. Exactly. Getting maybe the individual house fires, the small stuff that's there. The big stuff, the bigger ones have been knocked out by the planes, and they're going and getting the rest of the small ones and put it all out.
So the synergy is through the delivery, it's through the penetration, the distribution, the immune recognition, processing, and remodeling the tumor microenvironment, and all of that is activating this abscopal effect. Now, we're not just activating an acute innate immune response, but we're also recruiting and activating the adaptive immune response, right? Because, I mean, people go, okay, destroy the tumor. Yes, that's that acute local, which we want. But we also want this to be a time and spatial where it's also outside the tumor and it's long-term.
Yeah, and that gives a memory and it gives a long-term cures, right?
Yeah. So it's really, it's like people go, well, I had the flu. No, let me back up. That's not a great one. I had chicken pox.
Well, the flu, though, obviously because it's different versions, right? And so,
that's why it's chicken pox. So I got chicken pox. Okay. So you've activated the immune system. So you're going to have sustained memory, immune memory. Yeah. So that if that virus ever tries to reactivate again, we know that those patients have less issue with shingles later in life. But if they don't get exposed and then they get exposed later in life, they don't have that immunity, that defense, that long-term memory, boom, shingles becomes quite abrupt and aggressive.
Right, exactly.
So it really, it's there. And so it's not just a time, but it's also a spatial thing where it's local and it's distant, it's acute, and it's long-term, but it's because we're activating the immune system. We're priming the body's defense.
Yeah, creating essentially a vaccine against that cancer. So you're treating it simultaneously, you're getting rid of it, but you're also vaccinating the body against it. So should there be technically what you see, of course, this in the mouse models, is that once you cure the mouse of that cancer, you try to give it back to them. They don't get it. So and so that means that in humans, and particularly what you would see is crossover type cancers. For example, let's say you treated a BRCA related breast cancer. Probably the patient getting a BRCA related ovarian cancer would be less likely at that point. If you treated a KRAS mutated pancreatic cancer, then a future KRAS mutated colorectal cancer, probably less likely. So they have this protection against other cancers that would be of similar relation.
That's a good point, because I was having a discussion with a friend the other day about the word vaccination and what it means. It's interestingly enough, the origin of the word Latin means pertaining to cows. I don't think most people, they're like, vaccination. It's like, oh, what? How's that relate to a cow? Yeah. But the point here is it's about prevention. So when you talk about cancer vaccine here, it's about prevention. You're talking about prevention recurrence, prevention in secondary tumors. And so by activating that immune system, you are working preventatively while you target the tumor. So it's really kind of and I think this is one of the challenges that we have in the arena of cancer care, is there's too much sequential thinking. Too one-dimensional. Cancer's like quantum physics, and we're like down here just doing basic calculations.
Exactly.
And I think that's what you've been able to provide, Jason, is this ability to just say, no, I'm not limiting my thoughts here. It's like, let's just open it all up.
Yeah.
Let's just open it all up.
Now, I think that's in the difference, you see with the immunotherapy versus the older treatments of chemotherapy, is immunotherapy will make you healthier and would theoretically prevent future cancers, whereas chemotherapy is more likely to give you future cancers. so that's
and radiation. I mean, it's there,
right?
And everybody recognizes it, and there's always work to prevent it. So it's not like we're saying something that's not existent in the literature.
Yeah, exactly.
And so then people will often ask, well, where's the research? What's the studies, the evidence that supports this combination, this synergistic approach of intratumoral ablation and intratumoral immunotherapy? And that's a valid question. And we have to understand that in all science, as it relates to medicine, there are limiting factors, but we don't have a lot of limiting factors here because there's actually tons of preclinical studies, particularly animal models.
Great data. I mean, I think that the data is overwhelming. It's just surprising how often we can see this stuff where they do this amazing animal data. Like, oh, look at this, we did this, and then nobody does anything with it. But obviously we have, and we have, of course, the support of that. And now we have more and more human data coming out, and now there's more, clinical trials. And so, the movement is happening, right? It's there. And I think we're definitely picking up a lot of momentum, and I think we're going to see changes happen more rapidly. I think we had this, long time of a build up that was really slow, and it seemed like not much was happening, at least from other people doing it. And now I think it'll be catching on.
Yeah, and clearly, experience in terms of outcomes, they're speaking for themselves, and patients do the best of sharing their experience. Because as we've mentioned before, that one of the things is the targeting of the tumor, which is amazing, but it's the quality of life.
Yeah.
Because the standard right now is go through treatment, let's hope you make it, then let's work on recovery, then start to live.
Yeah.
Our patients, they don't stop living. And in fact, I would say they actually begin living anew with treatment.
Yeah, I mean, this makes them all, better and healthier in the end. I mean, obviously there can be some rough goes depending on the situation. And again, our biggest challenge is, if we got patients from fresh diagnosis, then that would be easy, and I think the patient would do really well. But that's not what we get. We get patients who've had all these problems, and now, they have tubes and stents and stuff. Their anatomy's been reworked. They're not the same. They've been treated with chemotherapies. Their immune system's weakened. They've had all these other issues, and now we get them as patients. So, a lot of times we're dealing with those type of problems, or the issues that it causes, and it certainly impedes our treatment. So, in the future, hopefully we get more and more people straight out of their first diagnosis, and not, waiting until their end of line, which is what we end up seeing the most part now. And I understand it, because the patients have the illusion, I have cancer, I'm going to go to my standard place, MD Anderson, Sloan Kettering, whoever, great cancer centers, and they're going to cure me. And first they have that illusion in a particular stage 4 patient, right? And then eventually that illusion starts to crash and then they realize, and then the reality hits. And at that point is when they start looking for other options, and that's when people would end up finding us. And so it's unfortunate that it's not sooner. But the thing is that, obviously we want other centers doing what we're doing. I mean, we want MD Anderson, we want Sloan Kettering, all those to do what we do, because we just want to help people. Unfortunately at this time, nobody, even people who might say that they do that we do, nobody does what we do, because they don't have the same drug options. We have far more advanced capabilities. It's unfortunate. I wish other people did, and they may say it, but they don't. And so, but in the future, hopefully they will, and we'll be happy to help them. So, we'll see, but we just want to change, cancer care better for everybody.
And on that note, people go, what do you mean all these tubes and everything? You've talked about, at least we've had private conversations about how in pancreatic cancer, if there's a biliary stent in place, and liver mets, the difference between the two in terms of outcome, that's with or without a biliary stent, night and day difference.
It's a big difference. Yeah, I mean, I see these cases, and a lot of times patient's got a biliary stent. Well, I think I can help them, but it's one you wish they just didn't have that. I mean, because they're going to have a lot more problems. Or patients with heavy bowel resections, or patients with, you see them where they remove their spleen, they've done all sorts of stuff to them. The patients they just don't have their body parts. they don't have things that they need. Spleen, probably you need it for a reason. I mean, actually, most of our body parts I think we need for a reason, and we probably shouldn't be taking any of them out. And that's but that's unfortunate.
And I wonder if that, if the stents, clearly it's a foreign body. The body is obviously something where, bacteria, biofilms, viromes, microbiomes, all these foreign agents, if you will, that are collected within tumors, if that is also playing a role in propagating the progression and immune evasion of those tumors where these foreign bodies are implanted. And you see this, like, for example, in breast cancer where they've got those markers in there, right?
Yeah, right. Yeah.
You continue to see these often hot spots around those markers.
Yeah.
It's like, well, if you got a tumor and it's described as a tumor that doesn't heal, a wound that does not heal, excuse me, and then you put a foreign body in it, what would you expect?
Yeah.
Aggravation, inflammatory response in that environment that's already abnormal.
Yeah, the body doesn't like these foreign things in it.
It likes its parts, as you said, and it doesn't like foreign parts added to it.
Yeah.
So, and studies have actually shown this to also be safe. So the synergy here is actually the two together are exponentially beneficial. Safe in human studies. Again, that cryoablation and the immunotherapy checkpoint inhibitor shown to be safe and effective, the combination rather than each individually alone. So now our job is to continue to help more patients, Jason, but also to spread the word and grow the number of doctors and practices that are actually helping more patients in not an escalating way, but a de-escalating way.
Yeah, exactly.
And it's through innovation and really your mind, because there's more to come, is there not?
Definitely.
Innovation never stops.
That's right.
Well, Jason, thanks for joining us here. I thought it was a great opportunity to bring to the front a common question patients will get. A recent patient from South Korea that will be joining us soon. But I thought let's tackle this and let's go through some specific points. And of course, always, if you want to learn more, check out the show notes. You'll see all the studies supporting it, and you can dive as deep as you want to. Thanks again, Jason. I look forward to seeing where the new innovations come, and we will see you on the next podcast.
Every day is a new opportunity to beat cancer.